I'm Devora Aharon. I'm one of the attending physicians at Reproductive Medicine Associates of New York. I'm based at our East Side location on 59th and Madison. Thank you all so much for being here. Today I'm going to be talking about egg freezing, talk through, how the process works, a little bit about reproductive biology and aging over time. So, as you've all likely heard, it gets harder to get pregnant as we get older, right? And that's mostly because of the eggs. So we're born with all the eggs we're ever going to have. And as we get older, the number of eggs declines and the quality of the eggs that are there also declines. So the number and the quality are kind of two separate things that both decline over time. Now, the purpose of egg freezing is kind of, take advantage of your reproductive potential when you're younger, when you have more eggs, higher quality of eggs that you can potentially use in the future to give yourself more options, more flexibility. It gives you a way of taking a little bit more control, gaining some flexibility in terms of planning and building your family in the future. So let's go into a little bit about ovarian aging. So, as I mentioned, as you know, we're born with all the eggs that we're ever going to have, right? And the number goes down over time. When we're born, we have about maybe 6 to 7 million eggs. Actually, when we're at 20 weeks gestation, that's the most eggs we're ever going to have. By the time we're born, it goes down to like 1 to 2 million eggs. By the time you hit puberty, it's at about 400,000. You ovulate over the course of your reproductive lifespan from puberty to menopause, maybe 400 to 500 eggs. All along that whole timeline, that 400,000 is declining till you hit menopause, which on average is at around age 50. Okay, and that's when there's basically no eggs left. Now, at the same time that the number of eggs is declining, the quality of the eggs is also declining. And it's actually the egg quality that's the most significant factor in terms of determining your likelihood of getting pregnant. Now, when we think about egg quality, what we're mostly thinking about is the number of chromosomes in the egg. Chromosomes are essentially packages of genetic material. So when we talk about number of chromosomes, we're talking about the amount of genetic material, not specific genes. You need to have the right amount of genetic material in order to create a healthy pregnancy. Every cell in the human body typically has 46 chromosomes. Eggs and sperm each have 23, so half of that. There's always a certain portion of eggs and sperm that we make that are chromosomally abnormal. But this affects eggs more so at a relatively young age. So really starting around age 35, the proportion of eggs that are abnormal starts to rise. Now, if you think about it, when you're trying to get pregnant, each time you ovulate, you release one egg. If that egg is chromosomally abnormal, it usually results in no pregnancy. If it does result in pregnancy, that pregnancy will usually miscarry, or it could result in a baby that has a disorder related to a specific abnormality, like Down syndrome, for example, but it basically won't result in a healthy pregnancy. And so as we get above 35, the chance that we ovulate an abnormal egg increases, and so it gets harder to get pregnant, rates of miscarriage and rates of Down syndrome go up. Now, this data here is giving some information about egg quality. This is information that actually comes from embryos that were tested as part of the IVF process. Eggs are each only one single cell. They're very delicate. We actually can't test eggs individually to know whether they are chromosomally normal. But when we fertilize eggs and make embryos in the lab, embryos are 1 to 200 cells. We can take a small biopsy from the embryo and send it for testing and find out whether that embryo is normal. So this is data that comes from over 15,000 embryos that were tested. It's showing the percent of embryos which are aneuploid, which means chromosomally abnormal, according to female age. So you can see as age goes up, the proportion of eggs that are abnormal rises. Now at baseline, kind of hovers around 30% abnormal, which is a significant portion. That's why even at younger ages, it can take some time to get pregnant, miscarriages can happen, but the majority of the eggs are normal. Past 35, the proportion that are abnormal starts to rise. And this is the main reason why people talk about fertility declining starting around age 35. Now, it's not like it's a sudden spike at 35 in the abnormalities, right? It's just that we're starting to see a change. By 38, 39, it's about 50% abnormal. By the time you're in your early 40s, that's when it really starts to jump each year, and each year can really make a difference. So 40, 41, 42, by 44, 45, we're getting to about 90% or more abnormal. And so it becomes much more rare to get pregnant with one's own eggs at these ages. Now, one thing that's important to keep in mind is that the uterus actually doesn't really age in terms of its ability to carry a pregnancy. We can actually create a pregnancy past 44, 45, even past menopause actually. by giving hormonal supplementation to the uterus and using a chromosomally normal embryo that's from an egg that was frozen when you were younger, or from an egg donor who's younger. It's the same concept. Okay, so likelihood of success is really tied very closely to age of the egg. And so that's the idea behind this. Okay, so how does it work? So when we are stimulating the ovaries for egg freezing or IVF, we're essentially rescuing eggs that would otherwise have been thrown away for that cycle. So how is that? So each month, let's say, at the beginning of a cycle, menstrual cycle, you get a period, the ovaries recruit or bring up a certain number of eggs into these small little follicles. Follicles are these little pockets of fluid in the ovary. And at the beginning of the cycle, really at any given time, we can see a certain number of these small antral follicles in the ovary. These antral follicles that we can see contain the eggs that have the potential to grow and ovulate in that cycle. Typically, over the course of the menstrual cycle, one follicle is designated as the dominant follicle. That follicle grows. As the follicle grows, the egg that's inside of it matures and prepares to ovulate. Then that follicle ruptures, the egg is released into the pelvis. The tube picks up the egg, and the egg has the potential to result in a pregnancy. The other follicles that were recruited at the beginning of that cycle will degenerate. Those eggs essentially die, they're thrown away. The next menstrual cycle, a new cohort, a new group of eggs is brought to the surface of the ovary. One will ovulate, the others will degenerate. In an egg freezing or IVF cycle, what we're doing is we're actually trying to stimulate multiple follicles to grow at one time. So the ovary looks something like this, with multiple follicles growing. And so we're essentially rescuing eggs that would otherwise have degenerated, been thrown away. In that cycle, you have the same number of eggs going forward. We're not reducing your egg count in any way. It doesn't affect your future fertility or timing of menopause at all. It's a question I get frequently. So this is what it looks like on ultrasound. So if you come in for egg freezing, this is kind of what you'll be seeing. It's a little bit grainy, but basically these are the antral baseline follicles. Each follicle has one egg. In a natural cycle, there's one single dominant follicle that will grow and ovulate, and the other follicles will become atretic or degenerate and essentially, be thrown away and die. In a stimulated cycle, an egg freezing or IVF cycle, it's the same process. We are trying to achieve multifollicular growth. So we're trying to get multiple eggs to grow and multiple follicles to grow and to produce mature eggs. So again, we're rescuing those eggs that would otherwise have been essentially wasted from that cycle. And that's also why we have the ability to do multiple cycles, because each menstrual cycle, every few weeks, there's a new cohort, a new group of eggs that is brought to the surface of the ovary for us to work with. We do this by giving hormones that your body makes on its own. We're giving it in higher doses. So the hypothalamus and the pituitary are these little glands inside your brain that produce hormones to stimulate the ovary to grow a follicle. So FSH, or follicle stimulating hormone, is the main hormone that causes follicle growth. It's typically produced in an amount to cause one follicle to grow. What we're doing during an egg freezing cycle is we're essentially giving FSH, a little bit of another hormone called LH. We're giving the FSH mainly in higher doses to try to get multiple follicles to grow instead of just the one that your body would naturally grow and ovulate. And so again, it's hormones that your body makes on its own that it's familiar with, just in higher amounts. So this is kind of what the process looks like. The whole thing is typically about a week and a half to 2 weeks in total. We start when you get a period. If you don't get periods, you may be sort of equivalent of the beginning of a menstrual cycle. We can start sort of randomly. If you are on a birth control pill, for example, that can help with scheduling the cycle. But we want to start when all the follicles are small, all the hormone levels are low, basically everything is baseline essentially. So let's say we're going with a period. You let us know when you get day 1. You come in on day 2 or day 3 for baseline blood work and ultrasound to get started. So we give the FSH and the LH as injections that you take 2 to 3 times a day. And while you're on the meds, you come in every 2 to 3 days, and then daily, usually as you get towards the end of the cycle, for early morning monitoring visits. The idea is that you come before work, before your day starts. We do blood work and ultrasound, see how things are looking. Typically, you're on the meds for about 8 to 10 days in total. So that's this day 3 to day 10 to 13 coming in for the monitoring and doing the injections. Once the follicles look ready, we give a trigger shot that triggers final maturation of the eggs. So the eggs are basically preparing to ovulate. But before you ovulate on your own internally, we do the egg retrieval. And so that's around, let's say, day 12 to 14 is the egg retrieval. The day of the egg retrieval, we look at the eggs under the microscope. We see how many mature eggs we've got. We give the immature eggs an opportunity to mature in the lab, and then we'll freeze those. So we freeze whatever eggs we can get. So this is the process of oocyte cryopreservation. It goes up till here. If we're freezing embryos, for example, the day of the egg retrieval, we combine the eggs with sperm and we grow the embryos. We freeze the embryos between day 5 and day 6, day 7 of embryo growth, and we can test those embryos. So that goes till about here. If we're doing an embryo transfer, it would be around that same timing that we freeze embryos. If we're using embryos in the future, if we're using eggs in the future, we thaw the eggs, combine the eggs with sperm, and then we can implant the embryo around day 5, 6, or 7. So this whole thing is the IVF process. So when we talk about egg freezing, embryo freezing, IVF, it's all the same process. The difference is just where we pause and freeze along the way, or thaw and pick up from there. This is kind of what an egg retrieval looks like. It's done under anesthesia, so you're asleep. It takes about 10 to 15 minutes. It's a pretty quick procedure. It's very low risk. Any invasive procedure does have some risk involved, but all the risks are very, very rare. So we use a vaginal ultrasound with a needle that goes along the ultrasound. The needle goes into the follicle, aspirates the fluid from the follicle, and the egg comes with the follicle. So this is what it looks like on ultrasound. So the ovary here has lots of follicles growing. Here's the needle coming through and puncturing the follicle. So in reality, this, in this picture, the ovary is kind of far from the vagina here. In reality, the ovary is really right up against the vagina during the procedure. Okay, so how many eggs can I expect to get? So that is based mostly on ovarian reserve testing. So ovarian reserve testing comes back to the number of eggs. And that is something that we can test for based on the antral follicle count and the AMH, or anti-Müllerian hormone level. Testing of the ovarian reserve, or the number of eggs that you have, helps to predict response to stimulation for egg freezing or IVF. So the antral follicle count is the number of those small follicles that we can see at baseline in the ovary. The number of those small antral follicles helps to predict how many eggs we may get, because those antral follicles contain the eggs that have the ability to respond to the stimulating medication that we're giving. We can't actually draw extra eggs out of the ovary. We're kind of working with what the ovary has brought up for us in that cycle. So by counting the number of antral follicles, we get a sense of how many eggs we might be able to get from one cycle. Now, it's not a perfect predictor. Not every follicle typically is going to grow. Not every one gives us an egg. Not every egg is mature. So it's not a guarantee of anything, but it gives at least some ballpark sense of how many eggs we might anticipate getting in one cycle. The other measure that we use is anti-Müllerian hormone, which is a hormone we can check in a blood test. And it basically is a number that correlates with your ovarian reserve, your overall egg count. It correlates with your antral follicle count, so they tend to go together. And it helps to predict response to stimulation. So with a higher AMH, we tend to get more eggs from an egg freezing cycle. With a low AMH, we tend to get fewer eggs from an egg freezing cycle. What's nice about the AMH is it can be tested at any time during the cycle. You don't need to come in at a certain time in your cycle. It's a pretty sort of consistent level. One thing that's very important to keep in mind is that the AMH level, the ovarian reserve testing, does not predict your natural fertility necessarily. Because when you're trying to get pregnant on your own, if you think about it, you're ovulating one egg at a time. Like we talked about earlier, what really matters is the quality of that one egg. That's mostly related to your age, that figure we looked at earlier with the increase in the abnormalities. So what's really most important is the quality of that one egg. It doesn't really matter if you have a lot of extra antral follicles or a few extra antral follicles. You're not using those. You're ovulating one egg at a time. Now that's when you're trying, unassisted. When we're doing fertility treatments, like with egg freezing or IVF, we're trying to get multiple follicles to grow, multiple eggs to mature in one cycle. And so where the ovarian reserve comes into play is, again, that it helps to predict response to fertility treatments. So it gives you kind of better chances for success with each cycle. If you have a lower ovarian reserve, you may need more cycles to have success. The ovarian reserve testing, the AMH level, does not predict your egg quality. Your egg quality, again, is related to age. And so if you're young and you have a low AMH, you still may get pregnant naturally easily. If you're, let's say, over 40 and you have a low AMH, it's pretty, normal. If you have a high AMH, it means you can get more eggs, and so you're more likely to get more normal eggs. But it doesn't tell us that your egg quality is going to be any higher than average based on age. So this is something important to keep in mind. Another thing is if you have been on a birth control pill for a long period of time, sometimes when we check the AMH level and the antral follicle count, it can be sort of temporarily or sort of falsely suppressed. It's not that it's affecting your actual ovarian reserve in any way. It's just that because when you're on the pill, your ovaries are not as active and you're not ovulating regularly. So when we check those numbers, the ovaries can be a little bit quieter and the numbers come back lower. If you stop the birth control pill for a couple months, usually the AMH level and the follicle count will go up. And so if you have been on birth control and you get your AMH level checked and it comes back low, just keep in mind that that may be a suppressed level. Your actual ovarian reserve may be higher. There's no, long-term impact on your ovarian reserve or your fertility. It's just kind of an in the moment, suppression type of thing. Okay, so let's say you decide to preserve fertility, you decide to go for egg freezing. So what are your chances for success? So it's important to keep in mind that there's no guarantees for success with fertility preservation. There's so many variables at play. You can have very high chances for success, but you sort of never know for sure how those eggs are going to do in the future. So there's a lot of stages that the eggs need to go through to get to a healthy embryo, to get to a healthy baby. So, for one thing, like we talked about earlier, eggs are each only one single cell. We actually can't test the eggs individually to know whether they're normal. So the proportion that are normal, we would just sort of guess based on your age, but it could be that for that group of eggs that month, it was just sort of randomly, more or fewer that were normal, and we won't know until we, go to make embryos down the line. And then not every egg survives the freezing and thawing process. So, thaw rates, at our center, at higher quality centers, tend to be 80, 90, even up to 100% in many thaws. Of the eggs that survive the thaw, maybe about 80% on average fertilize normally when we combine them with sperm. About 60% of those grow into high quality blastocyst embryos that could be tested. The proportion that are euploid or chromosomally normal is based on age. And so, that's where really age comes into play. So this is kind of a funnel that gives a little bit of a sense, this is talking specifically about IVF, but let's say you start off with 12 to 14 eggs, maybe only 9 to 11 are mature. Of those, about 3 to 4 grow into embryos, and maybe 2 or 3 of those are euploid or chromosomally normal. Once you have a euploid embryo, that embryo has about a 50 to 60% chance of resulting in a healthy live birth. Now, to put that into context, the natural fertility rate, if you take like healthy heterosexual couples having unprotected intercourse, it's about 20% per month per cycle. It's not that high. It usually takes a few months to have success. And so for a tested embryo, it's higher than that, but it's not 100%. It often takes 2 or sometimes 3 embryo transfers to get to success. So if you put all these numbers together, on average, about 10 to 15 eggs gives very high chances of having one baby. Now that can vary depending on age, but this is, sort of averages. Now, again, for any group of eggs, if you have 10 eggs, you could fall way above or way below those averages, right? And so you could get, from 10 eggs, let's say sometimes we could get 5 embryos, sometimes 1 embryo, sometimes 0. It's rare, but it can happen. So it's always important to have that in mind, that we don't know what we're going to get until we ultimately go to make those embryos. And so it's a good idea always to try to freeze extra eggs in case you have a higher drop off than average to kind of maximize your chances. This is a table from a study that was done looking at real patients who came back to use their eggs after they had frozen them in the past. And it showed that the best chances for success, about 70% chance of having a baby, was in a group of patients who froze their eggs when they were younger than 38 and froze 20 or more eggs. Now, if you're older than 38, some people say like, am I eligible? Is it worth it? It's worth it because when you're trying naturally, it's only going to get harder as you get older, right? So if you look at some of the other, parts of these tables, they still had babies, right? Wasn't 80%, but they still had probably better chances than they had based on their natural fertility at that time. So whatever you can freeze at whatever age can be worth it, because again, it's only going to get harder in the future. But if you are in your early 30s, let's say, and you're thinking about egg freezing, if you're not planning to try to get pregnant until, a few years from now, the younger you are when you go through the process, the more eggs you can get, the healthier those eggs will be, the better your chances of success if you need to use those eggs in the future. So how many eggs should I aim to freeze, right? It's like kind of can be hard to, some people say 15, 20, 30. It depends how many kids you want to have. It depends how old you're going to be when you start having your kids. You may not need to use the eggs for your first baby, but maybe for your second or third kid, right? Now there are a couple, sort of calculators out there that can help to kind of put like a percentage on this. This is often helpful after a first egg freezing cycle when you want to know, well, okay, what are my chances based on what I got? This calculator is based on a lot of extrapolated data. It doesn't necessarily apply individually to every person, but it gives kind of I think, a sort of a helpful framework. So you put in your age and the number of eggs. So let's say you're 35 years old, you do an egg freezing cycle, you were able to freeze 10 eggs. It gives you about a 69% chance of having at least one baby and a 30% chance of having two kids. So pretty good chances, right? But you may want to do another cycle to increase your chances more. If you do another cycle and you get 20 eggs, it gives you 90% chance of having one baby and a 66% chance of having two kids from those eggs. All right, so I'm going to pause there. If you have any questions, please put them in the chat. And I am now, seeing all of the comments from you. I was muted in the beginning. My apologies for that. Thanks for bearing with me and sticking around till we figured that out. So yes, please, if you have any questions, you can put them in the chat. Okay, so we've got one question. Are all of the medicines and shots self-administered? So typically, yes, they are injections that you do on your own at home. We have videos to help teach you. You can also sit down with a nurse and go over it. There is a service that's available where you can have a nurse come to your home to do the injections. It is typically an extra cost, but that's an option. Some people will do that through their whole cycle. Some people will do it just for the first night or two till you get the hang of it. I will say that it is very overwhelming for everybody to have to do inject yourself at home. But the vast majority of patients, once they do the first couple of days, will say that, it's easier than they thought it would be and kind of get the hang of it pretty quickly. So we have a question of cost of egg freezing. So that a lot of insurances do cover egg freezing, but it depends on your employer and the kind of benefits. For cost questions, I recommend to reach out to our clinic, and we can get you in touch with a financial advisor and kind of give you more detailed information about that. So another question, can we talk about low ovarian reserve? So low ovarian reserve, again, does not tell us that your eggs are going to be lower quality, right? It just tells us something about the number of eggs we can get. And so what it really just means is that you may need multiple cycles to get the same number of eggs, right? So let's say your goal is to freeze, 20 eggs. If you have a lower reserve and you get 7 eggs from one cycle, you may do 3 cycles to get over that 20 number. Once you have that number, the chance of success is again really based on your age. Doesn't matter if it took you 1 cycle or 3 cycles to get there. What matters really is that total overall number. Now, obviously doing 3 cycles is not such an easy thing, financially and with the time and everything. But if you're able to do multiple cycles, you can have really good chances for success in the future, even if you do have a lower ovarian reserve. But ultimately, it doesn't necessarily change your goal in terms of the total number that you want to get. Do you recommend people go off birth control or is the outcome still the same either way? So if your reserve is suppressed when you're on the birth control and you stop the birth control pill, you go right into your cycle, we may get fewer eggs in that cycle than if you were to give your ovaries more of a break off the pill, have that ovarian reserve recover, get more antral follicles to be available. That can sometimes take a month or two. Then we can actually get more eggs out of that cycle. Now, I have patients who come in and they've been on the pill for 10 years and they have like 40 follicles, which is a lot. So for those patients, I would not recommend that they need to take a break from the pill. They can go right into the cycle and they should be able to get a good number of eggs, right? So it kind of depends on the person, whether or not it seems that you're suppressed. It doesn't affect everybody in the same way. But if we are seeing a low AMH and you're on the pill, I typically do recommend going off the birth control pill for a month or two. We probably will be able to get more eggs out of each cycle. What is the average amount of weight gain associated with egg freezing? So there is, I would say, sort of a fair amount of water retention. This process makes you quite bloated. For one thing, as the ovaries are being stimulated, those follicles are growing from both ovaries, and you feel that, really bloated and sort of distended. And then kind of all over, you can have this sort of water retention and bloated feeling, and it's different on everybody. Not everybody has that, but some people have it to a more significant degree. So that could be a few pounds of water weight, actually. At the same time, we also recommend no high impact exercise because the ovaries are very large. There's a risk of ovarian torsion where the ovaries can twist on themselves. So you can do kind of low impact exercise, but between the bloating and the exercise limitations and your appetite may change just with all the hormone shifts and everything. Some people do put on some weight, but it's a relatively self-limited process, a week and a half to 2 weeks total. So typically it's not true weight gain in terms of like pounds. It's usually water weight that will go away over a few weeks. Are you able to transfer eggs across states? Yes, you can transfer eggs to a different clinic location. There's a couple ways to do things, though. Typically, we recommend to thaw and use the eggs in the clinic where they were frozen because that clinic has the same protocols. You'll probably have the best success rates in the same clinic. That being said, I would say at higher quality clinics, we tend to have very similar success rates, even if we're using eggs coming in from a different clinic. So we do take in eggs from other centers. And so, yes, you can transfer the eggs and use them in another clinic. You also can thaw the eggs and make embryos, even if you live somewhere else. When we thaw the eggs, we really just need the sperm, and then we can make the embryos. If you're planning an embryo transfer, you can do a lot of the prep elsewhere and travel in just for the actual procedure of the embryo transfer itself, where we place an embryo into the uterus. So there's a few different options if you are living somewhere else. What steps do you recommend women take to prepare for egg freezing, and how long would you prep for? So like dietary changes, substance like alcohol. So there is no recommendation to be like clean, quote unquote, for any certain amount of time. Um, Lifestyle things like diet, alcohol, exercise, these can to some degree influence egg quality. They can definitely affect fertility, but the effects are more subtle. By far, the biggest impact is age. And so, especially as you get, sort of closer to 40, when shorter amounts of time make a bigger difference, we do not recommend that you take months or any period of time for, lifestyle changes before doing treatment. If you're younger, in your early 30s, let's say a month or two is not going to make a difference, but there's no, specific recommendation of like a time frame to cut things out. That being said, the more you can do to have a healthier body, to be in a healthier state, will just improve your chances with egg freezing, with fertility treatments, with trying to conceive naturally in general. And so, as far as diet, there's some data that a Mediterranean style diet can be beneficial for fertility. What that means is like, lean proteins, a lot of fish, omega-3s, high in like whole fruits and vegetables, whole grain carbs, high protein, trying to avoid heavily processed foods, a lot of added refined sugars, trying to avoid, so that's diet. And then some other things to think about, trying to avoid toxins in the environment, chemicals added, plastics is a maybe. Um, Alcohol in moderation, I would say a couple drinks a week is okay. I typically recommend to try to avoid alcohol while you're on the medications just to be on the safe side. Avoiding marijuana. The one thing that we know definitely has a harmful impact is tobacco. So if you smoke cigarettes or even vaping, that can have a negative impact on your egg number, on your ovarian reserve, and also your egg quality. So that's a major one. Sleep can actually have an impact on fertility. There's actually, pretty good data on that. It's hard, with life, right, to get a good night's sleep every night. So I would say don't stress too much about it, but as much as you can, if you're preparing for this process or if you're going through the egg freezing cycle, to try to get, 7 to 8 hours of good quality sleep a night, it actually, may have some real benefit. Why is the process so expensive? It's a good question. It's mostly what's happening in the lab. So if you think about it, we're extracting this extremely valuable and delicate material. Each egg has the DNA to, have the DNA to create a person, right? Has that potential. And so the techniques that we use, the materials that we use, the expertise of the embryologists in the lab is costly. And so that's really where the majority of it comes from. And you want to be in a place, the lab quality is really what is the most important. That's where your eggs and your embryos are going to grow. That's where they're going to live. They're growing and outside the body. And so the environment and the way that they're cultured and frozen and taken care of is what's going to really matter the most in terms of your likelihood of success. And so that's where the cost comes into play. It is very expensive, but more and more insurances are covering it, fortunately. But it is difficult. What can you expect to feel through the medication process? So in terms of side effects, I would say the main side effect is bloating and cramping. So as those follicles are growing, as the ovaries are getting larger, you feel that bloating, you feel that space in your abdomen, really. And then after the egg retrieval, as the ovaries are recovering, the bloating and cramping can get worse. Often for a few days after the retrieval, it can get a little bit worse. Usually, then it starts to get better. By the time you get your period after the egg retrieval, which comes about a week to a week and a half later, that's when you feel pretty much back to normal. Everything kind of resets with that next period. You may still feel a little bit bloated for a couple weeks, but for the most part, you feel mostly back to normal when you get that period. So that's the main side effect. A lot of people feel very fatigued, tired on the meds. You can go about your normal life, you go to work, you can go out at night, you just need to make time to do the injections and come in for the monitoring visits. That being said, just because there's kind of a lot going on, I recommend to try to do it at a time that you don't have like a major presentation or something super stressful, just because it's a lot to deal with at once. And in case you are feeling kind of extra tired, moodiness affects some people. I would say it's not usually too extreme. Most people find that, it's not that they're kind of anticipating they might feel extra hormonal and moody, but it's usually not too bad. After the egg retrieval, actually, there is kind of a dip in hormones. And so that's oftentimes when people feel a little bit more sort of emotional and that moodiness. So that can happen. And it's good to be, sort of prepared for that and have a good support system during that time. Can you drink during the medication process? We sort of don't have evidence to say that drinking is going to harm anything, right? So if you are feeling really stressed out or you have an event and you want to have a glass of wine during the cycle, it's probably okay. But we sort of don't really know. But so to be on the safe side, we typically recommend to try to avoid drinking while you're on the medication. um, Is there an average amount of eggs retrieved for someone around 30 years old? So average is a little bit hard to say because it's really mostly based on the ovarian reserve. And then even with that reserve, there's always variability in terms of the response to stimulation, how many eggs are mature. But I would say for a 30-year-old, probably around 10 to 15 eggs is average. If you have a good response, it could be closer to 20. If you have a high reserve, it could be more than 20. If you have a very high reserve, it could be, more than 30. So there are some patients who do one cycle and are done, but I would say the majority of patients do more than one cycle. Even if they have a good response and get a good number in the first cycle, they'll often do another one to try to make more. A lot of people, again, find that after the first cycle, it sort of wasn't as bad as they thought. They're more accustomed to what to do now, and they are okay to do another one. And, once they're doing it, really want to try to get as many eggs as they can to give better chances. I would set as a general goal in total, ideally at least 20 eggs to have really good chances of one baby, and like 20 to 30 to have really good chances of 2 to 3 kids. But it's not a hard and fast number. If you have a lower ovarian reserve, and even with multiple cycles, you get less than that, it's still worth doing. And so it's really very individualized. It's not like one number for everybody. Um, is it possible to do this if you're 40 and have adenomyosis? It is definitely possible. It's all about likelihood for success, right? So at age 40, about 60% of the eggs are abnormal, about 40% are normal, right? So that's something to work with. That's where the ovarian reserve really comes into play. If you have a low reserve and you can only get 3 eggs from the cycle, the chance you're going to get a baby from those eggs at age 40 is fairly low. If you have a good reserve and you could get 10 eggs, maybe 4 of those eggs are normal, maybe one of those will grow into a healthy embryo, so it's definitely possible. And, when you're 41 or 42 and you're trying to get pregnant, it's only going to be harder, right? So that's why there's no like strict age cutoff. It's just a matter of understanding the likelihood of success, that it's not a guarantee. And, again, that it may take multiple cycles to have success, but it will give you more to work with than you will have in the future. um, so does repeating the cycle mean that the same eggs will be used from the initial step? So it's a new group of eggs. So at the beginning of the cycle, we do an ultrasound, we see a number of antral follicles. Those are the follicles, those are the eggs that we're trying to stimulate for that cycle. We extract whatever we can. The ovaries recover. About a week and a half later, you get a period. Everything kind of resets. And then there's a new group, a new cohort of follicles in that next period, in that next cycle. So it's a new group that we're working with, that we are trying to get to mature and extract. But the process is basically the same. Oftentimes, if you do a second cycle, we can learn something about how your ovaries responded in the first cycle and tweak our medications, tweak our timing, and get even more eggs in the second cycle. So everyone responds a little bit differently. We do the medication dosing and the protocol based on your numbers and your age, but even with those baseline numbers, everyone can respond differently. And so once we see how you've responded, we can often tweak things a little bit and do a little better in the second cycle. But for the most part, it's that same like week and a half to 2 weeks of stimulation, egg retrieval, recovery. When would you recommend embryo freezing versus egg freezing? So there are advantages to each, really. With egg freezing, we talked about how there's a lot of uncertainty in terms of how many eggs are chromosomally normal, how many eggs are going to thaw, how many eggs are going to grow into high quality embryos, right? We don't know the answers to those questions. When we make embryos, now we have more information about what you're working with at the end of the cycle. Embryos survive the freezing and thawing process a little bit better because they're bigger, they're more cells. It's more like a 98 to 99% thaw rate. So if you start off with 10 eggs and you know that you got 5 embryos versus 1 embryo, you have a better sense of what position you're in and if you need to do another cycle, for example. And that's the main advantage with embryo freezing. The advantage with egg freezing is mainly flexibility. You're not committed to the sperm source. If you fertilize eggs with sperm and make embryos, if you use those embryos, that's what the sperm source is going to be. So if you're looking for flexibility, if you're looking to give yourself more options for the future, egg freezing really is the way to go. It also is less expensive because with embryos, there's more steps to making the embryos in the lab, and that adds a lot of cost. One thing that we may look at on like an individual level in terms of testing results is that with a lower ovarian reserve, let's say with a very low ovarian reserve, if you can only get, let's say, 2 or 3 eggs from a cycle and you freeze those eggs, you really don't know if you're going to get any embryos from that cycle. But if you're making the embryos and you're lucky in terms of the embryo development, maybe you get 1 or 2 high quality embryos, even those 1 or 2 high quality embryos can give you very good chances for the future. So with a very low ovarian reserve, embryo freezing can potentially get you a little further if you have good embryo development, just because with a lower egg count, there's a lower likelihood for success. So you want to kind of have a little bit more of that assurance of what you're working with. With PCOS, AMH is often elevated, as is the follicle count. Does this change the use of this tool? So for the most part, I would say it's a numbers game. So with PCOS, we can often get a lot of eggs, a lot of embryos, have really good chances for success. It's an upside of PCOS, actually, that you can have a very high response to ovarian stimulation for egg freezing or IVF. That being said, with PCOS, sometimes we do see sort of subtle effects on egg quality and embryo quality. So sometimes when we do IVF and we make embryos in the lab from patients with PCOS who get a high number of eggs at the retrieval, sometimes we see that a lower portion of those eggs are mature and a lower portion grow into high quality embryos. But because we're starting off with so many eggs, we typically do still get a good number of embryos in the end. So we do typically do well. But it is something to keep in mind that if you got like 40 eggs, the proportion that grow into high quality embryos may be a little bit lower, but again, you can still typically get a good number in the end. Talked a little bit about the symptoms. There's a question about a non-stimulated natural cycle for egg retrieval. So I don't recommend doing that. You know, if you're stimulating and retrieving one egg, or not stimulating, but if you're just retrieving one egg, the chance that that egg is going to be mature and fertilize normally and get through all those stages to get to an embryo is quite low. So you're going through a lot of cost and an invasive procedure for very little return. The goal here really is to get as many eggs as you can to get multiple eggs from one cycle. So at 45 years old, what would be the estimate of eggs? You know, unfortunately, it's tough at 45 years old. Probably about 90% or more of the eggs are abnormal. And typically the ovarian reserve is also very low, so we typically can only get 1 or 2 eggs, and there's essentially a 90% chance that egg is going to be abnormal. So the chances for success are unfortunately very low at that age. If you're a rare person who has a high reserve for a 45-year-old and we can get a lot of eggs, there's a chance we can find a normal one, but it is difficult. It's very, very low chances for success, unfortunately. Over 20 eggs, the biggest factor of success being age is at the age at implantation or freezing. So this is an important distinction. The age at freezing is what matters. It's the age of the egg at the time that it's frozen. Then it's essentially frozen in time. The age of implantation does not really change your likelihood of success very much. Once you have a chromosomally normal embryo that's made from a chromosomally normal egg, that embryo has about that 50 to 60% chance of success, whether you're 35 at the time of implantation or 45 or even past menopause. The chance goes down very slightly with those ages, but it's a much smaller change than the change that we see coming from the egg. So what really matters is the age of the egg, much less so the age at the time of implantation. And that's why also using an egg donor can be very successful if you're in your late 40s and you don't have frozen eggs from when you were younger. Let's say if you use a healthy egg from an egg donor, you can have very high chances of getting pregnant. There's a question about omega-3 fatty acids. Those can be beneficial. I would say there's one supplement that can maybe help improve egg quality and egg number called coenzyme Q10. So that's one that I do recommend to patients. Omega-3 can also be somewhat beneficial. It's also helpful during pregnancy for fetal development. So it's a good one to take. As far as materials and ingredients that should be avoided, most of these things are like big question marks. So it's sort of a judgment call. I generally say, don't stress too much about these things. Like, you can dye your hair, you can do these kinds of things. If you want to be super careful, maybe try to avoid like, extra chemicals if you can, if it's not like adding too much stress to your life. It's really not clear that these things have a significant impact, maybe in like very, very high doses and very high amounts, but it's out there, it's in the environment, there's only so much you can do. Do you suggest starting with a comprehensive baseline at an OB/GYN? It doesn't hurt. A lot of patients will check their AMH with their OB/GYN. It's important to understand that it's not a test of your natural fertility. It's not going to tell you your likelihood of getting pregnant naturally. It's just kind of a starting point. If you find that you have a very low AMH, you may consider freezing eggs or embryos on the sooner side, sort of just in case. just because if you do have infertility down the line, it's going to be harder to have success with IVF at that point if you're already, having a low ovarian reserve. But it's not because it's telling you you're going to have infertility. Just scanning through some of these questions because we're getting a little lower on time. Would a self-injectomy affect likelihood of success? It really shouldn't. Once we're extracting the eggs, it's going to be mostly based on your age at the time. Whether or not you have your tubes, if you're going through egg freezing or IVF, really shouldn't make a difference. See, supplements or foods we kind of talked about. Do the medications vary based on age? They do vary based on age and the ovarian reserve. So we tailor the medication dose based on those things. Also, BMI comes into play. So typically with a lower ovarian reserve and a higher age, we give a higher dose of medication. So there's a question about weight loss. If you have low ovarian reserve, is it helpful to lose weight? Being significantly overweight can actually decrease the ovarian reserve. So could weight loss help a little bit? Maybe. I would generally say, weight loss can help with chances for success with fertility in general, with egg quality. And for general health, it's a good thing to be thinking about. I wouldn't necessarily delay an egg freezing cycle for the purpose of having like a specific weight loss goal, because again, we know that age has a very significant impact. Do you recommend cycles back to back or doing breaks? So really either works. We again often get a better response in a second cycle, oftentimes, because we can learn from that first cycle, but also because, there does seem to be maybe sort of an extra stimulatory effect in the subsequent cycle when those cycles are close together. There's no harm to doing cycles back to back. A lot of patients will do that to try to just kind of get it done. It's also fine to take a little break in between and do the cycles a couple months apart. The main downside is if you do it 6 months apart or a year apart, then age comes into play. But aside from that, there's really no clear benefit of doing them close together or spread apart. It's mostly what works for you and your life and your timeline. There's a question about paternal age. So older ages of the father, like as you get into the 40s and more so like 50s and 60s and beyond, does affect health of the child. It increases chances for autism, not as much for Down syndrome. So it doesn't increase the chromosome abnormalities so much because Down syndrome is a chromosome abnormality that's usually coming from the egg. But increasing paternal age does increase risk for autism, also some like neuropsychiatric disorders, potentially even childhood cancers. But they're more subtle effects. It's like a small increased rate. It's not like a huge, likelihood of any of those things. So if you froze eggs and you have a partner, would you recommend fertilizing and freezing embryos with your frozen eggs or doing a fresh cycle? So this is really a very individual scenario. It depends on your goals, the number of kids you want to have, when you're thinking about getting started, how many eggs you had frozen, your age at the time. If you're at an age where it's kind of important to know now what you have in terms of your eggs to know if you should do more cycles, you may want to thaw those eggs and see what you have. If you feel pretty confident that you want to make more, maybe save those eggs unfertilized as a backup to have some flexibility. Maybe you do a new cycle and make more embryos. So there's a lot of factors that go into play. There's no one right answer. There's different factors to consider on either side. So GLP-1 meds. During the egg retrieval process for egg freezing or IVF, you don't need to stop them for like a long period of time. There is some concern for risk with anesthesia if you're on GLP-1 antagonists. So we recommend to pause your GLP-1 for a week before a procedure with anesthesia. The egg freezing cycle is about a week and a half to 2 weeks total. So what we recommend is once you start the injections, hold off on your dose of the GLP-1 until after the egg retrieval, and then you can continue. Before pregnancy, there are some theoretical potential risks to a developing fetus. So we recommend to pause your GLP-1 agonist for a month to 2 months before pregnancy. But for an egg freezing or IVF process of an egg retrieval and extracting eggs or embryos, it's just that 1 week before. Um, okay, let's see. Can the lab help when developing embryos if the sperm morphology or levels are low? So that gets more at embryo freezing or IVF when you make the embryos, especially with frozen eggs, but oftentimes in general, we can do a procedure called ICSI or intracytoplasmic sperm injection, where we inject each egg with one sperm. Um, and that can really help get around almost all issues of male infertility. If the counts are very low, if the morphology is very low, by finding those normal looking sperm, we can have really good success. Sometimes when there's issues of sperm quality, we do still see lower rates of embryo development, embryo quality, so there can be some other challenges there. But by doing this process with IVF, we can have very good chances when there is abnormal sperm. We do accept patients who are over 45. It's always sort of a long discussion with the doctor about chances for success and your individual circumstances and numbers and everything. Let's see, we're at 6 o'clock now. So I just want to say thank you to everyone who joined. Thank you for your attention, your excellent questions. Please feel free to reach out, give us a call, schedule an appointment if you have any questions. Again, I appreciate you being here to learn about this important topic. I'll stay on for a couple more minutes and try to go through some more of these questions. So let's see, is the process couple friendly? It certainly is, whether you're doing this and you're single or you have a partner and you're freezing eggs, you're freezing embryos. We always tailor the treatment to the couple, same-sex couples, heterosexual couples. We have really diverse patients who come in for treatment. Let's see. Right, I think we've covered basically all the questions. Some are, kind of asking things we've talked about before. So thank you again, and hope you all have a wonderful evening.